Exam questions on cardiomyopathy. First question here. You are the new doctor in town, and on your first call day, a 55-year-old woman presents to the emergency room. On examination, you note that she has a low Glasgow Coma scale, which is 8 out of 15, and a thread pulse. She appears jaundiced, multiple spider nevia are present on her trunk, and she has massive ascites. Her jugular venous pressure is raised, and auscultation reveals third and fourth heart sounds. Her husband tells you that she has been a heavy drinker with poor dietary habits, and she had previously had liver trouble. She had begun to vomit blood the previous day. Blood was taken for emergency investigation, which showed the following results. Sodium is 129, you can see that's low. Potassium is 4.5, that is normal really. Urea is 7, that's above normal. Creatinine is 120, that's above normal. Glucose is 1.5, that is low. Ammonia is high. Acid base pH was 7.5, it is slightly alkaline. Partial pressure of carbon dioxide is 6.45, 6.5, that's high. SBC is 35, and so that's the standard. SBC is 35, so the bicarbonate is actually high. Liver function test, the total protein is 80, which is normal. Albumin is 20, which is low. Total bilirubin is 345. That is low. That is too high. Conjugated bilirubin is 290. That is also high. ALT, these are liver enzymes. ALT is schist, which is high. Alkaline phosphate, another liver enzyme, is 445. That is high. GGT, another liver enzyme, is also high. Give three likely causes of the patient Glasgow Coma scale. Is there anyone that wants to answer this one? What can cause a low Glasgow Coma scale? Anyone that wants to answer that one? So if you look at, yes, please be free. Thank you so much. So the accumulation of ammonia can be one cause of the low Glasgow Coma scale. Actually, what happens is that normally our body, like the GIT, we have got bacteria that will be producing urea, and urea is produced by from the breakdown of a lot of proteins in the body in the urea cycle. This urea is supposed to go to the liver to be converted to the actually uh, the ammonia is going to be produced in the body. Now the ammonia is toxic. All right, it's supposed to be the one going to the liver to be conjugated into something that is less toxic, which is the urea, because it is produced from a lot of breakdown of proteins in the body. So what is going to happen is that because of the elevated liver enzymes that we have seen, it means that the liver function is being compromised. If there is a compromisation of the liver function, what happens is that ammonia accumulates and it goes to the brain, and there it is going to result in what is known as hepatic encephalopathy. The liver has failed, ammonia has accumulated because you can't convert it to the less toxic urea, and so when that happens, ammonia goes to the brain. That is hepatic encephalopathy. Besides that, you can also see here, look at glucose. Glucose is 1.5. Hypoglycemia also can lead to altered mental function. And look at sodium. Sodium is low. So there is also electrolyte imbalance. So these three reasons can cause mental function. So the low GCS. What acid-base disturbance has this patient developed, and what is the most likely cause? Let's review this one. We want the acid-base disturbance that has developed and then the cause for that acid-base disturbance. Look at the pH. Let me write this so that it is going to be making more sense. Okay. Unfortunately, I can't write it for now. Okay. So look at the pH. Here is the pH 7.54. The pH is above normal. You know the normal is between 7.35 to 7.45. So this is meaning alkalosis. Now, alkalosis can be caused by gain of base or loss of acid. How can you gain base? Like if you have got a lot of bicarbonate, okay? If you have got a lot of bicarbonate, that will mean that you have gained base. And then how about the loss of acid? The loss of acid, we explain that in terms of carbon dioxide. So if you see low carbon dioxide, it means that you are breathing out a lot of carbon dioxide. Okay, if you are bringing, and carbon dioxide is actually hydrogen because it can be converted to hydrogen by reacting with water. So in if it was respiratory alkalosis, we were expecting carbon dioxide to be low. Okay, but this one, as you can see, carbon dioxide is very high, higher than normal. Why? So the problem here, the pH is high, SBC is also high. This is metabolic alkalosis. The reason as to why carbon dioxide is high is because it is a compensation. The body is trying to retain or to not to remove carbon dioxide so that that carbon dioxide can produce hydrogens that to be able to at least compensate for the metabolic alkalosis. Look at the pH 7.54. It's not too far from the normal, so there's actually some compensation here. So we are saying this is metabolic alkalosis with respiratory compensation. And what is the most likely cause? There are different things that can cause metabolic alkalosis, but for this question specifically, they've told us that there is actually vomiting happening. So when someone is vomiting, what they are doing is that they are losing hydrogen, and the loss of hydrogen means that you are going to be remaining overall with a lot of base. So that is going to be it. So vomiting, you can see where is the vomiting. She had begun to vomit blood the previous day. So that vomiting can lead to the loss of hydrogen. And then see what is the most likely explanation or explanations for the total protein remaining normal despite the low levels of albumin. You can see total protein is 8, which is normal, albumin is 20, which is low. Possible explanation for that is the total protein can remain normal because of an increase in globulins. You know, I've got different types of globulins, like the beta globulins, the antibodies, gamma globulins, the clotting factors. These guys, they can be produced from other parts of the body, not the liver. So globulin, the albumin, which is produced by the liver, can be reduced because the liver in this condition is failing. But from other body parts, it might, the other proteins, the globulins will be produced. So that is why the other globulins are compensating for what is low here, the low albumin. So that's why the total ends up being normal. What life-threatening complication may arise in this patient because of ascites? Remember when we are discussing, we said ascites can lead to spontaneous bacterial peritonitis because the bacteria will start moving out, going into the peritoneum as the blood is moving out of these distended veins because of the heart failure that is happening. What underlying cardiac pathology might have developed in this patient? So this patient has got, if you read properly, the question appears jaundice and massive. From the history, we've been told that, where is the statement I'm looking for? Her husband tells you that she has been a heavy drinker. You can see we say that dilated cardiomyopathy can be caused by alcohol consumption, beriberi, things like cocaine, toxicity, Chagas disease, Coxsackie virus. So alcohol causes dilated cardiomyopathy. We can also call it as alcoholic cardiomyopathy. So that is the cardiac pathology that can develop here. It's actually this cardiac pathology that will be the one that will be leading to ascites, because one complication of the cardiomyopathy is actually heart failure that leads to ascites. What X-ray finding would support your finding? In cardiomyopathy, there is a dilatation of the heart, so there's going to be cardiomegaly. So that will be seen on X-ray. The next question here. James was a young 40-year-old and energetic athlete who played soccer for one of the big football clubs in Europe. He suddenly collapsed and died while on the soccer pitch 2 days before. An autopsy was conducted. The only significant finding was that he had an enlarged heart, approximately 490 grams. The left ventricular free wall was normal, but the interventricular septum was enlarged. There were no muscular or valvular defects. Note that before his death, James was reported to have been very healthy. He did not have a history of suffering from hypertension. What is your diagnosis in light of the history and the postmortem finding? Provide the complete diagnosis. Anyone that can help with this one? What will be your diagnosis? Thank you so much. So there is hypertrophic cardiomyopathy. The explanations for hypertrophic cardiomyopathy will look at the enlargement of the interventricular septum, and then besides that there were no muscular or valvular defects. Okay, not that, but just a sudden collapsing, that is a feature of hypertrophic cardiomyopathy because of the ventricular fibrillation and ventricular tachycardia. What are the histological findings of this condition? So someone that has got hypertrophic cardiomyopathy. Number one, we've said that the septum is going to enlarge, right? It has hypertrophied. So there is actually myocardial hypertrophy. And besides the hypertrophy of the myocardium, if you look at the cells themselves, they are increasing. There are a lot of them, but then they are disorganized. So there is myocardial disarray. There is disorganized arrangement of cardiac muscle fibers. There is actually also going to be interstitial fibrosis. Okay, there's going to be a lot of fibrous tissue between the muscle cells. So these are some of the findings that we're able to see in heart failure, in cardiomyopathy. Which part of the heart would be affected if it was older and had a long history of hypertension? So for the hypertensives, most of the time, the part that is affected is the left side of the heart, specifically the left ventricular free wall. Okay, so that would lead to concentric left ventricular hypertrophy. Remember, just the same hypertrophic cardiomyopathy, it can involve the septum, or it can be concentric, involving like the free wall of the ventricles. So with a prolonged period of blood pressure, high blood pressure, hypertension, there's going to be failure of the left ventricle because of left ventricular free wall hypertrophy, leading to concentric left ventricular hypertrophy. Describe the pathogenesis of hypertensive heart disease. How can hypertension lead to heart disease? Not too complex. If someone is hypertensive, high blood pressure, what is going to happen is that the high blood pressure, there's going to be uh, the if you have got high blood pressure and it's chronic, it's been there for a long period of time, there's going to be increase. It's going to increase the resistance against which the heart must pump, right? Like the heart is trying by all means to pump through. Maybe you have got small blood vessels because of the high blood pressure. The heart is trying to pump against such a pressure, and so what happens is that there's going to be the left side of the heart trying to push by all means. So the left ventricle is going to start hypertrophying. Okay, and then as the muscle thickens, it's trying to overcome that resistance. But then as this is happening, what happens later on is basically the heart will not be able to accommodate that for good. Okay, it will not be able to accommodate that for good, and so what happens, the heart is going to start failing. It will just be weakened, it will become weak, and so it can't pump blood anymore. Besides that, when someone is hypertensive, the renin-angiotensin or aldosterone system and the sympathetic nervous system are going to be activated, and that will promote further hypertrophy and fibrosis. And so hypertension can cause changes in the structure of the blood vessels that can lead into reduced coronary reserve, because there are these changes happening to the blood vessels. And besides that, there's going to be also problems with the blood that is actually going to the actual heart, because remember the heart is actually hypertrophying, so blood will not be enough going to the actual heart. That can lead to ischemia. So that's what we can say about hypertensive heart disease. The problem is prolonged high blood pressure. The heart is trying to work on by all means against that pressure to be able to pump blood, and so it hypertrophies, and later on it is going to fail. So that is it for this class.